The routine eye exam is no longer routine. Today, it can detect early signs of Alzheimer's, predict glaucoma progression, and uncover systemic disease. The future of medicine may start in the retina.
Eye care is evolving faster than ever. Today, an eye exam is no longer just about updating a prescription. It can uncover early signs of systemic disease and, in some cases, save a life. Breakthrough diagnostic technologies, novel medications, and advanced surgical techniques are rapidly coming online, all designed to preserve vision with greater precision and fewer side effects. So, what's real? What's coming next? And what should patients and doctors be paying attention to? Today's guest, Dr. Chris Wroten, is a Louisiana optometric physician and nationally recognized leader in ocular disease and clinical education. He has served as Chief Operating Officer of the Wroten Eye Clinics, overseeing 3 offices in Southwest Louisiana, a 2-time president of the Optometry Association of Louisiana. Dr. Chris has lectured internationally, participated in clinical research, and received multiple professional honors. Today, Dr. Wroten joins us to share what's truly new in eye care and what breakthroughs on the horizon may soon change how we diagnose disease, protect vision, and improve lives. Dr. Chris Wroten, thank you for joining me today on the Open Your Eyes podcast with Dr. Kerry Gelb.
Kerry, it's great to be with you. Certainly a ton of respect for you and seeing the Open Your Eyes documentary when it first came out and following your podcasts over the years. It's an honor to be here with you today.
Well, Chris, I really appreciate that. That is super kind of you to say that. There's so much new technology happening in eye care, and about 181 million people get their eyes examined every year. And we want to give them kind of an idea, give them, what to expect when they go into the eye doctor's office. So we're going to get right into it. Some of the new technologies that we're using in visual fields or taking people's side vision. I know I have the big one, the Zeiss perimeter. But now there's virtual reality perimeters, like the kids playing the games. Are those any good? Do they actually work? With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.
That's a great question. That's a staggering number. And certainly probably in your practice and most of our practices, it's the same. That visual field is not a fun test for most patients. We usually tease them and say it's painless to take, but you might die of boredom from it. And those that have to do it over and over again, it certainly is a challenge, that boring test, but so critical, obviously, when we're managing glaucoma and macular degeneration, neuro eye disease. It's a simple test that really is the poor man's MRI, as it's been called over the years. And so, back in 2021, in January of 2021, one of our perimeters went down. And if you recall what was going on at that time, we were in the middle of the second wave of COVID, so to speak. And so there were manufacturing delays all over the world. And our perimeter went down, and we have a pretty big medical practice. And so it certainly is going to impact our quality of care, meeting standard of care. And so fortunately, the manufacturer was able to remote in and to do some diagnostics on it. And then they said, well, we got good news and bad news for you. The good news is it's only a $500 part. The bad news is that with production delays, it's 6 months before we can get it. And we said, well, that's just not going to work. And so we had been watching a couple of these virtual reality perimeters as they were making their way down the pipeline. And I didn't realize that any had been approved yet. And so we went and looked at some of the traditional perimeters, your Humphreys and those ones that have been around for a while. And of course, we're looking at a price tag there of $24,000, give or take a little bit at the time on the MSRP. And there certainly is a secondhand market for used ones, but they always come with some level of uncertainty when it comes to that. And so I had recently seen a little blurb about one of the virtual reality perimeters and checked back in on it. And literally a week before, it had finally gotten FDA approval. And so I was excited about that potential opportunity and went back and pulled some journal articles just to see, all right, how valid are these? Well, it's an exciting new technology. I want to make sure that they're valid. Are we going to miss anything with progression with glaucoma with these? How repeatable are they? All of those things. And multiple journal articles at that time, it all indicated yes, they are repeatable, they are reliable, and they are valid, and they are comparable to what we've had to that point in time with the standard of care perimeters. And so a company had just launched it, and they were offering a free 30-day trial and no questions asked, money back guarantee, and it was only $8,000 at the time instead of 24,000. And I love the fact that didn't have to tie up a room with a large box in it, and so it could be done on a patient as they waited in an exam chair, and it could go from room to room, and it would wirelessly download their results into the EHR. And patients we found loved it. I had some initial concerns with, especially with some of our older patients who tend to be the higher percentage of population that does our visual field tests. How would they respond to it? Would they be able to do it? Could we get valid, repeatable results? And we actually found that our ability to get valid data improved with the virtual reality perimeters versus the standard. And there's always patients that are not going to be able to give us valid, visual field data just because they're poor test takers or there are other challenges. But we found it to work really, really well, and it was well received by our patients. There certainly was a wow factor with it. And there's all kinds of new virtual reality perimeters on the market today. Most of them are 4K resolution or better. There's a couple on the market now that are a little different. The first ones that came out were all based on the Oculus Rift VR headset. As you said, the gamers are all familiar with those. But there's a couple new ones on the market that are lighter. They're more of like a wraparound Oakley style device, a little lighter, and some of them now even do a little bit better job covering the perimeter of the visual field. So it's a much more true photopic, a true scotopic environment in which that visual field is done. Some of the original ones, you could argue maybe were a little more mesopic as far as the conditions because there was a little bit of peripheral light that would get in. But the data was still very valid. The printouts all look exactly the same as what we're used to analyzing. Now, the algorithms are slightly different, and you can't take a traditional, Humphreys serial analysis and plug it in and get the same results necessarily. But when it comes to monitoring for progression, we've seen it work really, really well and be very, very well received by patients. And as I say, now there's pupil trackers built into these, so you can essentially eliminate fixation losses. Because if that patient's eye moves, the target automatically moves to adjust for any eye movement before it's challenged to the retina. Now they've got built-in virtual reality and voice recognition software with it so that you can use it to measure visual acuity, some of these, and there's an AI assistant that tells the patient as they're looking through that VR headset, read the lowest row of letters that you can see on this chart. And it challenges one eye at a time, and they verbalize the answer, TZV-ECL. It recognizes that, records it as 20/20, drops it into your EHR. They'll now check for APDs. You can do a simulated ptosis field, taped and untaped, without actually having to apply tape to the lids. You now have all kinds of different other add-on options with those, whether that's color vision, whether that's some of the other unique things that we do from time to time. There's some that'll do cover tests for you now automatically as well, and extraocular motility, so you can get EOMs, motilities, fields, pupil tracking technology, all of this built in. And so it's really exciting to see some of these technologies that just make sense in eye care.
It's interesting to have a ptosis built into it. How many patients come in, they have a ptosis and they want to be covered by insurance to get the ptosis fixed, and you don't have to tape the lid.
Yeah, it's really amazing technologies that are out there. Now, the prices have obviously gone up on some of these as they've continued to develop and add some of these other protocol options, but even, dark adaptation in some of these devices that are out there. And we've got some really big names in eye care that are behind a number of these. And so there's a couple of new companies, but you've got places like Bascom Palmer that have spun off some for-profit entities that specialize in these. And a couple of these companies started with wearables for patients with low vision. So they were devices to help patients patients navigate an environment when they had significantly reduced vision. And so it was a very easy transition for them to change that headset, reprogram it to do virtual reality perimetry.
How about this new perimeter by Conan, where it tests both eyes at the same time? It's totally objective. The patient doesn't have to do anything except look at the target. Tell us about that.
Well, that's certainly something that I'm intrigued by. I don't have any personal firsthand experience with it yet, so I'd love to get my hands on it and see and go back and review what some of the clinical trial data looks and how well that actually correlates with a traditional subjective field. But I think we would all agree it would be awesome if we had a truly objective field. And the way this one works is it basically challenges the retina with the stimulus, and if there's any pupil response that's measured whatsoever, it assumes that that is a positive ability to see that stimulus. And so simultaneously challenges each eye. And again, it's recording using infrared and some pupil tracking and various technologies there, that if that stimulus produces any type of constriction in the pupil, that that is a positive stimulus response. And so they get credit for seeing that stimulus. And so again, I think there's a lot still to be uncovered with that, but I'm excited about the potential there.
And a lot of things that we're going to talk about, it's impossible for you to have all these things and to have tested it, but the fact that you've learned about it and know about it is really amazing. How about eye kinetics? I have that in my office, objective pupil testing. I like it. And do you know anything about that? Any experience with it?
I do know a little bit about it. Again, don't have it personally here. There's a couple of devices that will do something similar. I really like the idea. I mean, most of us delegate to our staff when it comes to pupil testing and the entrance skills. And of course, if there's any question, we'll go back and double check it ourselves. But even as an experienced clinician at times, it is difficult to tell, you know, is there anisocoria present, and is that just a trace APD? And so at times it can be a challenge. And so I do think this is an opportunity where technology can step in, and AI algorithms can be utilized here in an appropriate way to help us be even more accurate in determining. Because if you look at the statistics, there's a significant percentage of the population that has anisocoria. And I think if we look at our charts, it's probably not that same percentage of patients that are documented with it in our offices. And so, pupil testing can always be a challenge, and it can lead to some really challenging outcomes if patients do have issues with Horner's and those types of neurologic conditions that can affect pupils. And so anything we can do to better document and objectively and subjectively assess pupil response, I think is going to be beneficial to patients and doctors alike.
And for the public listening, why is it important to assess pupils?
Well, certainly there's a condition called Horner syndrome that can be due to things like a tumor on the top of the lung, the apex of the lung. And many times that is a malignancy that's there. And one of the things that it causes is affects the pupil on one eye versus the other. And so we see one eye smaller pupil than the other. It can be very subtle at times. Sometimes there's a ptosis or a drooping of the eyelid associated with it as well. Sometimes one side of the face may not sweat as much as the other. Those are kind of the classic three symptoms associated with Horner's pupil or Horner syndrome. But a number of other neurologic conditions, because of the way the eye is innervated, those nerves leave the spinal column and they go to the eye. And so if there's a lesion, if there's a stroke, if there is a tumor, something that's growing, an aneurysm that should not be there, and begins to press on those little delicate nerves, then one of the first things we see is the pupil affected. And so being able to accurately diagnose and assess those pupils is critical.
About 10 years ago, if I have my dates right, they they were talking about an eye care that we look in the peripheral part of the retina and we see drusen, but some of that drusen actually may be amyloid, and that the optometrist may be the earliest person, the earliest doctor to pick up Alzheimer's disease. Talk about this new scope. I know Topcom put some money into it, RetiSpec, where we're going to be able to see amyloid plaques sooner to see that people may be at risk of Alzheimer's.
Yeah, these amyloid plaques it's a variation of a protein that will show up. It's a biomarker essentially in the retina. And so it looks like some of the really, really high resolution OCTs may be able to pick it up. Some of the more recent advances that most of us don't yet have in our offices because of the cost. But this RetiSpec is basically it's hyperspectral imaging, which, traditional imaging in a retinal camera, or even just a camera that a the public would use has red, green, and blue, light filters in it, or detects red, green, and blue. Those are the three primary colors. Well, for years, the military, especially with some of their smart bombs and things, as they're determining where targets are and what needs to be bombed and not bombed, those types of things, they've brought to light this hyperspectral imaging, which looks at multiple different pixels and colors and variations of colors besides just the three primary red, green, and blue. And so this company, Retispec, actually has an add-on that's put on top of a retinal camera that most of us have in our offices, and it allows the ability to assess much more colors than just a traditional color fundus camera or retinal camera would, which then allows those amyloid plaques to be observed in the retina, and those can be correlated with risks and even diagnosis of Alzheimer's. It's still a very big challenge for most of our neurologists to come up with an Alzheimer's diagnosis. It's pretty invasive. Most of the time it's a PET scan, which is a very expensive scan to have done, and or a lumbar puncture or spinal tap. And people aren't lining up to have a needle stuck in between their spinal column to have that done and the cerebrospinal fluid assessed, but that ultimately is still the standard of care for diagnosis of Alzheimer's. And so as we see Alzheimer's continue to bloom with all the things that you've talked about and open your eyes and everything since then, it's just there are reasons it's exploding, and we've got to get to the root cause of those. But for those that have it, to be able to diagnose it sooner, less invasively, and hopefully intervene in such a way early on that we can prevent the late stage effects and symptoms of Alzheimer's would be huge. And it's something that, again, will allow us to look in the back of the eye and see what's going on.
And there's been some studies that show the sensitivity is 86%, the specificity is 80%. So
Those are huge.
This is huge, and they have this camera. They're showing this at Alzheimer's societies conferences. So this is a big talk at these conferences, and people are going to be coming into our offices, and we're going to be able to tell if they have amyloid. And the question always comes up is, well, do patients really want to know if they're at risk for having Alzheimer's? But the medications are getting better, and if there's medications and if there's lifestyle changes that could be done to help prevent it, then sure, people want to know so they could do something to prevent it. If it was something they couldn't do anything about, then maybe they wouldn't want to know. But we're going to talk about epigenetics in a little bit, and
Yeah.
by using the concept of epigenetics, the changes could be made.
Absolutely. And that's the exciting piece, is that we do have some medications that are in the pipeline that are out now, but even more importantly, those lifestyle changes and nutritional supplementation and dietary changes and a little more exercise, all of those things can really make a difference. And that's what it's all about. When we can make a positive impact on patients' quality of life, that's when they benefit and we benefit, and we just have the job satisfaction we all desire.
I did a great podcast with Dale Bredesen on preventing Alzheimer's. And at that time, he had 36, he called it 36 holes in the roof that had to be plugged to decrease the risk. I think maybe now he has a few more, up to 40. But listening to that podcast that I did with Dale Bredesen, and I've done some others on Alzheimer's, which it would be very helpful for people that are concerned about it. Let's
Yeah.
move on to the next instrument, which is the corneal confocal microscopy. I almost bought one of these about 10 years ago. I was fascinated. You can see the little nerves and, maybe diabetic retinopathy. We could pick up diabetic neuropathy, rather, if somebody's going to be getting diabetic neuropathy sooner or they have it, to confirm it. Tell us about the confocal microscope. Is it something worth having for a regular optometrist like myself, who sees regular patients? A lot of disease patients, of course, I have a big eye disease practice, but I want to give my patients the best possible care. So tell me
Sure.
about this. And I didn't pull the trigger, and maybe I should have.
Well, I'm not necessarily sure on that, Carrie, and I don't know what the current cost of a corneal confocal microscope is. Most of them that are out now seem to be in academic institutions, research setting, and tertiary referral centers. And so it may not be something right now that can be utilized a ton, but there's some interesting research that continues to develop with this. So this is definitely more of an old school technology. It's a black and white image for the most part, and as you said, it allows us to see actually the nerves in the cornea. So for our eye care providers, it's the ability to essentially do what an OCT does, looking at the nerves in the retina and around the optic nerve, but yet this is in the front of the eye in the cornea. And so we probably heard about it in school and maybe haven't seen much about it since then, but there's some interesting work that's been done that does correlate the loss of those nerve endings, the basal nerve plexus in the cornea, with the risk for peripheral neuropathy in type 1 diabetics. And so we're talking about a systemic disease with a systemic manifestation outside of the eyes, and yet we're able to look at the corneal nerve endings and potentially even predict who's at highest risk for that with a non-invasive image of those corneal nerves. It's also being looked at with Parkinson's disease, with MS as possibly a diagnostic for those things. So again, another tool that's potentially available to us that may become more and more prominent and may be something that we do want to look at investing in our practices if we have a disease population, even as a primary eye care provider, so that we can better identify who's at risk for those things, so that we can get with the endocrinologist and we can, hey, this patient is showing changes in their corneal nerves that we can see. And so studies show that there's an increased risk for them developing peripheral neuropathy and maybe needing intervention, at a higher level now. So more aggressive lifestyle changes, more aggressive medications to control blood sugar levels, those types of things. And so I don't know that for the average OD, this is something that they need to jump on at the right off the bat, but it is something I think that we all need to be aware of. And it may be something that could be incorporated with some of our other instrumentation coming up, but it's another diagnostic that's been around for a while that we're starting to see kind of come full circle and show the ability to detect a lot of things. Even when COVID hit, it actually showed who was at highest risk for developing long COVID symptoms. And so those nerves that are in the cornea are accessible to us with these imaging techniques and technologies. And it kind of makes sense, right? I mean, it's whole body. When we see what's happening in the eye, it's usually happening elsewhere too.
You've done such a great job of compiling these new technologies and medications. I just really want to thank you for doing this. The next one I'm really interested in is being able to detect apoptosis of retinal cells, DARC, so DARC. And this will tell us of this progression of glaucoma very early, but you have to inject the dye into the body to do it. So maybe it's not ready for prime time yet, but this is something that's very interesting to tell if somebody's going to progress with glaucoma because the retinal cells are starting to die.
Absolutely. And so this is again a technology that's still in the pipeline, not FDA approved yet, but for doctors and even members of the public that may be listening to us, what happens is a cell starts to die. There's some proteins that are on the inside of the cell, and as the cell begins to die, those proteins get exposed to the outer wall or outer surface of the cell. And now there's a dye that can be injected into the arm, and as that dye flows through the retina, the dye binds to the proteins that have been exposed to the outer surface of the cell wall in those cells that are starting to die. And the problem with apoptosis, it is obviously for the non-doctors, non-clinicians who are watching, apoptosis is the process of cell dying, cell death. And the problem is it's kind of like the snowball downhill analogy that when one cell starts to die, oftentimes the one that's right next to it begins to do the same thing, and the next one and the next one. And so our ability to detect that early on before the cell is actually dead is significant. Now the question is, can we intervene at that point and do something to stop further cell death? And with glaucoma, we know we have a number of options, whether that's interventional glaucoma, again, lifestyle and diet changes, additional medications. And so an AI algorithm has actually been used with the DARC technology so that it basically takes a photograph of the retina after the dye has been injected into the vein, and it analyzes the patterns of where the dye is taken up, because the dye will fluoresce. And so if we shine a certain wavelength of light into the retina, it highlights and comes back to us, and those patterns can be assessed. And we're seeing the ability to detect glaucoma progression up to 18 months earlier than our current standard of care with studies. And so 18 months is a huge head start to know if a patient's worsening. We're not having to wait for, 30% of the retinal nerve fibrillator to be dead to show up on a visual field. We don't have to wait even for an OCT to see loss of ganglion cells and those things that we monitor on a routine basis for our patients with glaucoma. But to be able to catch it 18 months earlier and preserve that sight, I think could be a huge, huge impact for our patients that do have glaucoma.
I hope that they'll be able to come up with a drink, a pill, or even an
Yep.
eye drop to be able to do this so people don't have to get an IV injection.
I 100% agree. And, we can do, when I was early in my practice, the practice I was at, we were able to do fluorescein angiograms. And the doctor that I was with, Dr. David Talley at West Tennessee Eye, we actually did a study looking at oral fluorescein for a fluorescein angiogram, so we didn't have to do the intracubital injection, and we actually got fairly good results with it. So I'm with you 100%. I hope maybe there will be a dye that can be part of a drink or possibly even a topical that would do the same thing. And the technologies are developing with drug delivery that I think will allow that at some point in the not too distant future.
There's many people in healthcare, especially in integrative healthcare, that feel mitochondrial dysfunction is the beginning of almost all disease. And now
Yep.
there's a flavoprotein fluorescence that can be used to tell if there's mitochondrial dysfunction at the level of the retina for an indicator of glaucoma. Can you explain that? That sounds pretty interesting.
Yeah, this is catching it even earlier than the dark technology would. So by the time those proteins are presented at the surface of the cell, that cell has already started the process of dying. And so the mitochondria, as we all remember from junior high and high school biology, is the power plant of cells. It's ATP is produced, the adenosine triphosphate there, and so there is absolutely a huge burgeoning area of research looking at mitochondrial dysfunction in a whole host of diseases, not just eye diseases, but systemic disease and autoimmune disease and pretty much every disease process that you can imagine. The mitochondria is being investigated as a potential source of the damage and a potential source of treatment or prevention of disease. And that's what really excites me the most is when we can get to the point where possibly we can actually prevent disease and then reverse damage that may already be there. So flavoprotein fluorescence is very similar. And so what we start to see is as the cell undergoes stress, it hasn't yet started apoptosis, so it hasn't started that irreversible to this point process of dying. Again, we have these proteins that begin to increase in number within the cell, and they, similar to what we saw with dark, will fluoresce when a certain wavelength of light is shined at them. And so they essentially glow, and we can detect them in the back of the eye, again, for glaucoma. And, with the dark technology, even with this flavoprotein fluorescence, tough to say. We can think of cell death that occurs in almost every disease process in the eye that we see. So glaucoma is certainly one that's got the bulk of the attention at the moment, but macular degeneration, diabetic retinopathy, all of the inherited retinal dystrophies and diseases that we see, all of those things are also prime candidates for these diagnostic technologies as well.
And we'd probably be able to pick up systemic disease, because
Absolutely.
mitochondria is dying, your body's starting to die. So this is great technology that we could for the future. Let's talk about color vision. Jay Neitz has a color vision testing. Tell us a little bit about that and that advanced color vision.
Well, I've kind of come around to being a fan of color vision testing after not doing it, to my chagrin now for many, many years early on in my career. And if we think back to what the incidence of color vision deficiency is worldwide, it's 1 in 12 males and 1 in 200 females. And if we all do the math, I mean, how many men did we see over the last 365 days? Well, studies say 1 in every 12 of those had some form of color vision deficiency. And how many females? 1 in every 200 of those had some form of color vision deficiency. Differences being the inheritance pattern. So it's more common, obviously, in men than in women. And it doesn't mean color blindness. Again, we know that as clinicians. But again, for the members of the public that may be watching, we're not necessarily talking about the inability to detect any colors. We're talking about the inability to differentiate certain colors on the color spectrum that are very close together, that whether that's reds and greens or blues and yellows. And there certainly are a small percentage of patients that have true color blindness and they just don't detect anything. Achromatopsia is the term for that. And so I really didn't do much color vision testing early on in my career, largely because there wasn't a whole lot we could do about it. I mean, other than just, tell mom that little Johnny is not going to be able to work on the bomb squad. He's not going to be able to be a pilot. Probably not going to be able to work at the railroad because of the red and the green lights that they have to be able to differentiate, and the red wires and the green wires on the bomb squad don't want to cut the wrong one, etc. But now we're actually seeing more and more the ability to enhance patients' quality of life with filters and lenses and even apps that can be downloaded on a phone these days. And those apps change all the time at your favorite app store, but they do allow the patient to take a smartphone camera. And if they're trying to pick out a wardrobe, it'll help them better coordinate a wardrobe by using the camera of the smartphone to help do that. And we're seeing research develop with Jay and Maureen Knights there at the University of Washington. It's a husband and wife PhD research team has got a lab where they're focused in the Department of Ophthalmology on gene mutations and what occurs there. And then the process of doing that, they have identified the cause of red-green color deficiency in squirrel monkeys. And so they've been doing a lot of gene research that we may talk about a little bit better with that, but there may be something coming down the pipeline that's even better than what we currently have to help patients who have some of these color vision deficiency issues. And, there's now multiple online tests for color vision screening. And now we even have better advanced color vision testing technologies where we're starting to see studies published that show what we all learned in optometry school, and that's obviously that as optic nerve disease progresses, as glaucoma progresses, there's an effect on color vision. As macular degeneration progresses, we see some loss and impact on color vision. Now, an Ishihara plate test won't catch that, but there are new very specific tests, a number of them that are computerized, that function very similarly to a visual field. They're very specific, very detailed, and they will monitor over time like a serial analysis on a visual field will for progression of acquired color vision deficiency. And it looks like that functional loss of color vision perception may actually, we know it's more sensitive than a visual field because, again, visual fields, we have to have about 30% loss of nerve fiber layer to see a defect show. And so we can catch it earlier than with a visual field on the functional side. It, again, can allow us to get more aggressive with therapies and lifestyle changes and other interventional therapies to help patients. And so we now have an ability, I think, to enhance the quality of life for those with inherited color vision deficiencies. And now we're starting to see more and more color vision may actually be something as a diagnostic that we can use with progressive disease.
Neitz, it's Neitz. His
Yeah.
kit is, I looked it up, it's $75. Now I have the advanced color vision from Conan, the Color DX, and that was significantly more money than that from a clinician to buy. And we use it a lot. And,
Yeah.
especially if someone's at risk for glaucoma or has glaucoma. And, and we find it to be very effective. But here it is a much less expensive. You can get started, I guess, for $75. I haven't used it, but something I never heard about until I looked over your notes, and this is really something could be very special.
It is designed to be a screener. So again, it wouldn't be eligible for the CPT code to bill for the advanced color vision testing, but it simultaneously checks for red, green, and blue, yellow. The Knight's color vision test does. Pediatric patients can do it just as easily as adult patients. It doesn't require a specific test distance and doesn't require any special lighting, which we all probably have gotten a little slack with. But if we recall, Ishihara is supposed to be done at a certain distance in a certain lighting setting, and so to get the most accurate results. But yeah, it's exciting to see because there's a number of these that are on the market now.
And thanks for clarifying that that's a screener. It's not a
Yeah.
diagnostic test like Color DX. So talk to me about these N-chromo lenses. Have you used them? Do they actually work?
I think probably many people watching have heard of the Enchroma lenses. They basically it's a company that took a computer algorithm and they analyzed where there's the most overlap of red and green on the color spectrum, and they created selective filters to try to filter out where there's the most overlap of red and green in an attempt to try to enhance a patient's ability to tell contrast differences probably more than anything. And you can sign up to be a provider. We are at our practice. We've had some patients that have just absolutely loved it. It's not for everyone. The nice thing with it is they developed an app, a color vision screening app as well, to try to better identify who's going to potentially benefit from their lenses. Their lenses are available in plano and clear and tinted. You can get progressive lenses with them. So there's quite a range of refractive correction that can be put in the lenses with the filters that are there. You can go to YouTube and you can find a whole bunch of videos that have been posted by those patients who have gotten them, and it's not edited. It's not done by the company. Just patients posted, and some of them are tear jerkers for sure. I mean, there's a lot of bleeps and tears as people put them on, and so there does seem to be some subset of the color vision deficiency population that really has a pretty strong response to those. If you do sign up as a provider, I think they will send you a kit that's got some Plano lenses in them so patients can actually try them out before buying them to see if they would benefit from them. We've used filters and for a long time with various contact lenses over the years and filters in just filtered sheets to try to help with contrast for patients who have some vision loss with varying degrees of success. This does appear, in my opinion, to be a little bit better than those that we've had in the past, but it's basically just selective filtering, and there's other companies and other even ODs who've developed similar types of technologies, and so anything I think we could do to help with our patients in navigating their day-to-day life who have these deficiencies could be very, very beneficial.
And in real world, people they couldn't match colors for clothing.
Yeah,
They may be teased when they got dressed because of the way their clothes looked. This
yeah,
would help with something like that.
absolutely.
So let's move over to biotherapies. Tell me about stem cells. The cell therapy, is it really here now, or is it something that we have to look through for the future? I know there's some stem cell therapy that's approved with
Yeah,
cancer,
yeah.
definitely approved for cancers, immune disorders. But tell me about stem cell therapy.
Well, when we talk about biotherapies in general, there's three main categories we would say, and we'll probably touch a little bit on each of them. Epigenetics is one, which essentially attempts to use diet and hormones to alter genetic expression in a positive way, whereas we know bad behaviors, bad diet, lack of exercise, medications we take with side effects, all those can cause some bad, gene mutations and expression of genes we don't want expressed. And so the thinking with epigenetics is, can we use other things to do that? Cell therapy is a little different. We're actually taking intact live cells and we're introducing them into the patient, either in a particular part of the body or a certain area. And so those cells can come from the patient themselves. They can be autologous cells. So we now can harvest cells from the fatty tissue of the skin. They can be engineered to become just about any cell. So we can take these pluripotent cells that won a Nobel Peace Prize for the discoverer of those back in 2006. And it's the basic building block of a cell, and that basic building block can be used to differentiate into a retinal pigment epithelial cell or a corneal endothelial cell, or different cell types throughout the body, which is kind of exciting, provided that we can do it in a way that's safe and produces the benefits that we want without any unnecessary side effects. Or those cells can come from outside a person's own cellular tissue, and it can be a donor cell that's brought in that is hopefully in some way creating us an opportunity to cure or reduce disease. I do think cell therapy and gene therapy are still a little ways off in the eyes. There's a lot of research right now with cell therapy, specifically in the cornea. Worldwide, there is a dearth of corneal donors. And so those who have corneal disease, especially in second and third world countries, it's one of the leading causes of blindness. And there's just not enough donor tissue to do, or even doctors to provide the services to do a corneal transplant to restore a patient's ability to see because of some of the corneal disease that's out there. And so there's the thinking that, especially in Japan, I believe they're already using it in Japan. Two different companies, Helios and Fuji, both now have cell lines that are being used to replace damaged corneas in Japan. And so Asia is obviously a big hot spot for cell therapy and gene therapy. China kind of led the way, and there's some reasons for that with some of their human rights issues, and being a little more cavalier perhaps at times with some of the studies that they do. But that certainly, I think, is still something that holds promise for us in the future. And obviously the big third area with biotherapies is gene therapy, and gene therapy is not necessarily introducing live intact cells into the body. It's introducing genetic code, the instructions, the cookbook to actually alter proteins and either cause the body to make more proteins that fight disease or to make less proteins that are causing disease, or even to produce a new protein that maybe is not native to the patient in such a way that it creates a therapeutic benefit. And so those are the three big areas that are kind of competing for research dollars. It's very similar to the days, I guess, of Beta and VHS, who are old enough to remember those two technologies, and then high def, DVDs and Blu-ray DVDs, and what was going to be the big winner there. And so I think there's probably enough in the pipeline with all three of these areas that we'll see some continued advancements with them. But I am excited about cell therapy as a potential option specifically.
You feel cell therapy is ahead of gene therapy at this point?
I do. I think, surprisingly, or perhaps not surprisingly to some, I think cell therapy is generally considered slightly safer to this point. Gene therapy offers the opportunity, I think, to maybe do more, but I think there's still some concerns. We even this past year we saw 2 deaths reported in the media with patients that had undergone a gene therapy for a specific form of a muscular dystrophy, and in both of those instances, what was thought to be a benign adenoviral vector was used. So the virus was used to carry the genetic code into the host's cells, and it looks like liver failure was a result of the adenoviral vector that was used. And so that's still very rare. And in both of these patients, we're talking about a disease process that in and of itself carries a fair amount of morbidity and mortality. And so maybe can't say with 100% certainty that, the patient would not have perhaps passed away on their own from the disease that was attempting to be treated, but there was definite liver failure, and there's definite indications that in these 2 individuals that perhaps it was the viral vector that contributed to the liver failure that ultimately led to their untimely passing. And so gene therapy, I think, holds perhaps even more promise than cell therapy. But I think we certainly need to do our due diligence to make sure that we, do no harm when it comes to gene therapy. So I think it's still probably a little bit further down the pipeline. Although we do have some gene therapies FDA approved now too, including, one for the eyes.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you.